right, Mike, I'm going to turn it to you. I know that you had kind of some more things to share about, like, what do we mean when we're talking about mobile integrated health, and maybe some more information about, and God, I'm the worst person with acronyms. So I'm going to go like WACs and RCWs, and you're going to tell us like what all that means in the existing policy environment.
Yeah, thanks. That's where I know we struggled with sort of defining some of this stuff, which is there actually isn't anything in the WAC or the RCWs that really lend to what we're doing. They're pretty specific for paramedics in particular. And, I know a lot of the legislation is really written around paramedics doing one specific type of work, which is, critical care work out there. And so that's just the limitation. In fact, the recent COVID response, I think, opened up some of that concern, if you will, especially with the emergency declaration that paramedics could, for example, do swabbing in the field and give immunizations, which is not normally something a paramedic can do. I know it's driven that little aspect alone has driven us crazy over the years, because we can do a lot of advanced skills on people, yet you can't give them a flu shot. And so, it's things like that I think we would want to address in that would give that wide flexibility depending on the kind of community that you work in. My colleagues down in King County, for example, while paramedics are doing some of this work, there are also a lot of EMTs doing this work. And so the legislation wouldn't be necessarily aimed at paramedics in particular. I think we'd want to have a wider flexibility at the EMT level, because we found out in King County that the EMTs can do a lot of this work quite well too. And a little bit of the model that we had down there was having a paramedic as sort of a program manager, and then several EMTs helping with that work. But even with that particular setup, there was a lot of questions, and which is what type of education do you have to go out and suggest case management for a patient? Do you have counseling skills? What is your knowledge about the social services system generally? And so some of those types of ideas. Ben Russell, sitting next to me here in the building, he's hiding over here. He, along with another community paramedic, had actually taken education from an out-of-state college. I know a couple of our Redmond colleagues did as well, to sort of establish what that's like. And so, this varies from state to state. I looked at some of the California regulations, which, are okay. I like the Minnesota model was actually really good, because it provides in that legislation specific educational training backgrounds with a certification, requires in-service time with clinics and social services providers and that kind of thing. So, I think that's the gap, just from kind of where I sit, which is, how can we create a sort of some well-rounded legislation that will serve the deep inner urban density of Seattle, all the way out to our small little town in Glacier, Washington, or Skykomish, Washington, where services really are the same. And I want to say that's what I found really to be not much different in the deep urban environment as opposed to the rural environment, which those same gaps, those same social determinants of healthcare are existent in both. And a lot of times I thought it was more the rural area that were suffering from these types of disparities, but it's not. It's the entire areas, and it's all based on the type of populations of patients you serve, and all those gaps in healthcare that we all see in every community. So I think that's, I guess where I'd want to start is, filling those gaps in those RCWs that we need to, and I'm probably using the WAC versus the RCW, but both in those existing would be developed to say, hey, this is a community paramedic, this is a community EMT, and these are all the things that we can do in the state under that.
So can I ask a question? Because for some reason, I thought, like in the last legislative session, that there was some legislation passed to allow for reimbursement for community paramedicine, even though there were no dollars attached to it. But are you saying that even within that there weren't really clear definitions or role clarification?
Yeah, the FD Cares legislation, in fact, I believe Sean Maxwell was primary on helping that legislation down there. And the CARES legislation simply allows the fire departments to develop a revenue stream, for alternate destination, alternate transport. I know
Gotcha.
Kent has used it down there, and they've partnered with a hospital with a nurse EMT type of response. I don't know if anybody's on from down there that might be able to describe that a little bit better, but basically it allowed the fire departments to develop a revenue stream on that. And thanks for reminding me about that, because another piece of this community paramedic is reimbursement for services for these alternate transportations and alternate services. Right now we don't collect unless we take a person to the emergency room, and paramedics are not federally qualified health providers that can bill for those services, such as like a nurse practitioner. So another piece of this would be, how can we build in a reimbursement mechanism for these community paramedic visits, and can we get the insurance companies in on this as well as Medicare, Medicaid? We feel like that we could probably save the insurance companies a lot of money with, for example, in our situation up here. Right now, our priority is high utilizers of the system. So our community paramedics try to intercept those high utilizers. And right now, it's a 15, isn't it? So if you had more than 15 911 calls or 15 ED visits within a year, that person would be asked to enroll in our program up here, which is called Grace. But we've got so many more people under that 15 threshold, we just can't get to them. And we have patients that call EMS 100 plus times a year. So and there's no incentive to not take that particular patient to the ED every time. So you go out, you see them, ED, they pay the bill, then it's in that cycle. So we feel like we could save a lot of money for the hospitals, for the insurance companies, and some of these pre-hospital programs that would keep them out of those services. So that is a big piece of this, is figuring out how to get reimbursement.
So you had sent Lindsay some questions that you were hoping kind of the group could chew on and maybe give you some feedback on. And it looks like the first one, and Lindsay's probably going to put this in the chat box, is, and maybe Mike, you could start with like the phrase mobile integrated health and that related to community paramedicine. Because I think one of your questions was like asking everyone on the call, what does mobile integrated health mean to them? And so Lindsay can stick that in the chat box, but is that a term that is replacing community paramedicine? Like what's the relationship between those two?
I think generally there's been various nomenclature, if you will, to the programs. I know just personally, I end up leaning to mobile integrated healthcare because there's a lot of components to what this community paramedic does. Along with the increased scope of practice, a paramedic might be able to offer medication adjustments at home, for example. As telehealth is being developed rapidly now with the COVID, we think about what does it look like where a patient calls 911, they don't seem sick on the phone, we can divert that call for an hour or two, and then a community paramedic goes out, or maybe even our nurse practitioner goes out, evaluates that patient, and have an encrypted conversation, leave that patient at home, and maybe be able to go to the pharmacy and fill that med for that patient, or adjust their medications there. Do children checks out in the rural community, immunizations, etc., and brings in a wide variety of skills. Also with the social work, with the case management and motivated interviewing to get people navigated. So it's no longer going out and figuring out the emergency in 10 minutes and getting them to the hospital. It becomes a wide range of things. And one of the things that we learned up here in Whatcom County, which has been really valuable, is that we've been able to map out most all of our community service organizations, and actually a lot of because of what ACH has done in the last 3 years of getting all these communities together. And when I talk to home health, when I talk to the emergency room, even physicians, there's a lot of frequency in other areas that we feel we could get ahead of before, for example, I have to go to the emergency department. So there's a lot of pieces to that. And I know our paramedics here in Whatcom County are seeing all those. In fact, Ben Russell was working with a fall patient here a couple of months ago, just trying to get rails and stuff in that house, so to prevent this gentleman from falling who'd fallen half a dozen times in a previous year. So it's that type of outreach that kind of generalizes it. I think across the nation, the person is generally known as a community paramedic. And we position our program as a community health program that could offer mobile integrated health services if we expanded out. Currently in Bellingham, we call it our community health service, our community paramedic service, which is attached to our GRACE program, ground response and coordinated engagement program. So I think that would be something to talk about as a group is, yeah, what does mobile integrated healthcare mean to you? And if that becomes a term accepted by the state, maybe that's the term that's represented in the legislature too, as we build something like this out. So,
Liz, to tag on to what Mike's saying on MIH, it actually started up in, I think it was 1996 is when the whole program was foreseen for the paramedic EMS scope of work. And the idea was all the way back then is to do exactly what we're now doing. It just took us a few decades to get there. And that is exactly it. Pre-hospital, meeting up with hospital, clinical, and other types of home health care services. And it's outlined pretty good of what the program was expected to be back then. And I think now with the community paramedic, we're starting to catch up to what was thought of a long time ago. And another issue with Mike was talking about, one thing we've been looking at as far, and we can get into this later, but reimbursements for what we do in the field for treating and seeing patients, there's a potential that it affects our GEMT reimbursements as far as what we do on our side, and that we may not be able to make money on it. We may be able to charge for it, but we'll decrease our reimbursements. And I think that's something at a later point of this conversation we probably should dive into a bit to see where we're at with that. We may be spinning our wheels if we're not going to be making any additional finances based on what we're doing now compared to charging for our services.
that's a very good point, Darren, and thanks, yeah, because right now, I know for our area, what is really fueling the community paramedics is those GEMT monies. So Whatcom County runs on a countywide levy, similar to King County, 29 cents on the 1,000. And you know, our medic unit, our budgets are wrapped up in that levy. And we received those GMT funds as well in the last 3 years, which has really been a great shot in the arm. Otherwise, without that GEMT, we wouldn't be talking about these programs right now. I mean, they wouldn't have happened. And so that is a really good thing to keep in mind is we don't want, because that's all related to response, right? So all of a sudden, if we reduce our response by 50%, oh my gosh, that could be $500,000 or more for some places out there. So I think it'd be really important to see how we separate that from a response. And that's another thing that I did learn with the WAC and the RCW is that sort of technically, we aren't allowed to go knock on people's doors and say, hey, can we put you in a program? The way that people enroll through this, they have had to come in through the 911 system at some point, right? So, you know, if we get a call from a neighbor that says, hey, you know, my neighbor's struggling over here, but they've never really called 911, that's not really something we're probably going to be doing. We would want to have that. I mean, you know, we would try to direct the person to other community services. And so I do think about that reimbursement and how that could be sort of separated from the response mode with some of this stuff, because we do get referrals like that, even though they haven't been in the 911 system.
So can I just ask like a first grade question for us, probably especially for our team? GEMT.
That's a ground emergency medic transport. It's a kind of a gap payment for what was sort of a underpayment for mostly basic life support operations. It started in California, been into it for about 5 or 6 years. And it's a very complicated calculation formula. It took them 5 or 6 years to get there. But the short story on is that for fire departments that participate, based on call volume, types of calls, et cetera, Medicaid rather, reimburses that fire department for monies on that calculation. So for example, per medic unit up here running about 8,000, 10,000 calls each. I think we were getting about 600, 700,000 per medic unit per year on that. It's a little bit more. I see it as one bulk sum coming into the levy, and I think it's been about $1.5 million to the levy this year for us that we put in the levy and then redistribute that back out in programs. And so it's a medium stable program. I don't think anybody banks on that money as a steady revenue source. We'll see what happens in the next few years with GEMT, but that's more of a reimbursement. So I don't, at least my budget, I do not depend on that as a revenue. Once it's in the fund, then we redistribute it. So we just don't operate with money that may or may not be there from year to year.
So Mike, you've posed this question, like, what does mobile integrated health mean to the folks on this call? You know, we have kind of a couple of options. One is you all could type things in the chat box, or you could keep kind of just talking like Darren jumped in. Do you have a preference for how we kind of walk through this?
No, either way, Liz, I would like to hear some of the voices out there and,
Yeah.
you know, just make sure I'm in the lane. You know, I've come up with wacky ideas over the years, so. But,
which is why I like.
Can you guys hear me okay?
Yeah, jump on in. Go ahead.
You guys hear me?
Yep.
So this is Eric Cooper, and I'm sorry, I'm in the car, so I can't use the chat box. I think for clarity, I think this has been a great discussion. There's a couple things. The RCWs require acts of legislation to change, while the WACs were able to change during periods of WAC review, which we're actually doing now at the state. So the WACs are currently being reviewed and updated. So that's a lot easier to make changes in. There is the CARES legislation, which allows the EMS providers to operate outside of their normal scope of practice, which included a scene of an emergency. And so I think that should be separated from some of the other goals that we're talking about. I think mobile integrated health is a better term. A lot of counties in the state of Washington don't have paramedics at all. They only have EMTs. So we shouldn't necessarily come up with something that would deprive them of the ability to utilize any rule changes or legislation changes because they don't have access to paramedics. So it should include the use of EMTs. Also, I think for rural communities, if we put in legislation, which is hard to change and undo, a hard and fast requirement for education, that could be cost prohibitive for them, and we need to be considerate of that. The other issue that I think comes up, which everybody's hit on well, is the big problem is reimbursement. Rule change to kind of expand that scope of practice is certainly something we need to consider. Reimbursement is the big challenge, and I find that challenge is usually with the healthcare authority. While we were able to do the alternative destinations and get billing and reimbursement for it, the healthcare authority made it very difficult for us to do. They gave us a lot of challenges in following through with the reimbursement end. And I think addressing people in that group is going to be a huge opportunity for anybody who's trying to make a change on reimbursement. We've got to get them on board and on board early because they give us a lot of challenges.
Awesome. Eric, can you, since you didn't get to introduce yourself in the chat box, just like where you're from?
I'm the Snohomish County EMS Medical Director.
Awesome. Thank you. So I can just call on people based on where you are on my like Hollywood Squares screen here. So Rich Llewellyn, anything you want to jump in on?
No, I'm just kind of here to observe. Everett does not currently have a community paramedic program. It's something we've looked at, but we are struggling with our budgets and in particular for the rest of this year and next year. We have brainstormed a couple ideas as far as how to become involved, but we're just in the early stages and just sitting in on a conversation, not really lurking because you can see me, but I am sitting in the corner watching.
Awesome. We're glad you're there. That's great.
Liz,
Dean, oops. Sorry, somebody jumped in. Who was that?
it's Nicole.
Hi there. Go for it.
I was just going to jump in because I got some hot things that I want to ask. So on this conversation, there's a couple things. like Dr. Cooper said, I'm curious why the healthcare authority has created such barriers for us. And I've also heard that some of the chiefs have had this struggle because they don't want to give up that GEMT money. And I will say, you know, going from the line to CRP, this is such a needed service. Like, we are that middle person, right, between the ER, their doctors, and what's happening at home. That once I tell people who we are, they're like, we can't get enough of you. But I also think there's some problems if we have it in Whatcom County and we have it in North, but we don't have it in Everett and Marysville, and we don't have a lot in District 7. So in South County, I'd really like to know, how can we expand or even collaborate as CRPs so that we can spread this out to everyone? Because these are critical people that are not going to have change until we step in. And I'm curious how we, at least for South County, my dispatch can't dispatch me by myself. So we have continual clients that they have to be dispatched by 911. So the crews are already started. When I know, I mean, I got 30 clients that I know it's not a medical problem. It is a mental health problem, but I can't go unless they get dispatched. So usually the crews show up to make sure, and we have to cover all of our bases. And sure as always, they didn't even need 911. We just know. We already know. I could probably call in and find out, but I can't turn anybody back. And so I'd like the ability in our, with the healthcare authority, to say we actually are medical professionals and we know something. We know what we're doing, but we're sort of treated in this space of, you better have a medic unit show up, or you're, you know, just like that conversation before, we can't give shots. Well, I already give a shot, but I can't give a flu shot. Like, why is there a limit on our ability to do things? Because again, in South County, like, all I can see is how we can expand more, and people are turning to us to get the referrals. But it seems like our leaders in the healthcare authority has this block on, I almost feel like they don't think that I actually have education. That's almost how it feels sometimes. And I have a lot of education.
Nicole, actually, I think I have an answer for that. So the fire departments, I think, are the ones who bill for services. I believe this is how it was explained to me. For a provider to bill for services, you have to be a registered provider with a national number that allows you to bill for services. And I think that's where the challenge was with what we have now as our community resource paramedics. You're not a provider who can bill as a provider. And so provider billing is different than fire department billing. And so that's where one of the challenges on specifically having the services reimbursed in that kind of way, because that involves more of a national issue about, I think, how providers get paid in general. So I think that's part of the problem. Now, that was different on the alternative destinations. There was a bunch of rigmarole with paperwork and forms and all these other things that made it challenging. So that is one of the issues that has to be addressed on a larger scale, is how it's reimbursed. As you all know, the fire departments get reimbursed for transporting patients to the hospital. They don't get reimbursed for providing care in homes, and that's a whole different, I guess, reimbursement model.
That's
Got
really
it.
helpful.
Yeah.
Thank you.
Thanks, Dr. Cooper.
Jim Reinhardt.
Well, there's a lot to unpack here. I guess to follow up on what Dr. Cooper was saying, who's not only our Snohomish County Medical Program Director, but he's my department's specific supervising physician. The way that the paradigm is set up right now is that Washington State, and I guess really the federal government, incentivizes fire departments to transport to the emergency department. Like, like Darren mentioned, the GEMT reimbursement for transporting Medicaid patients. If I, as a community paramedic, keep somebody out of the emergency department, which saves untold amounts of healthcare dollars and keeps our units in our district more often, it benefits financially the healthcare system on the whole. But as far as the Tulalip Bay Fire Department, Fire District 15, we're losing on each one of those transports that we don't take to the hospital, we're losing ostensibly $1,500. So it's kind of a paradox in that the more good I do in the community, the more dire the financial impact it is on our fire district. And so that's something that first and foremost we need to fervently address, I think. Secondly, I think that one of the big barriers is the fact that the Department of Health has a very rigid structure by which paramedics and in fact EMTs operate, and it's kind of the tail wagging the dog. And what I mean by that is, and Dr. Cooper and actually everybody else in this room can attest to this, is as a paramedic, I am empowered to, by my own clinical decision making, anesthetize, sedate, anesthetize, paralyze, and intubate an elderly woman for septicemia, but my scope of practice does not allow me to dip her urine to make sure she's not getting a urinary tract infection in the first place. And that is a real fundamental flaw with our system, and it's going to be slow to change. So that's a second thing we need to address, is that our scope of practice needs to be defined in a way that allows us to do some pretty common sense skills. I'm a graduate of the Community Paramedic College at Hennepin, and there are others in the room who are also graduates of that school, which afforded me a skill set that can keep people out of the emergency department. It's not even really very invasive skills. They're pretty common sense. But the Washington State Department of Health and the EMS office doesn't empower me to employ any of those simple things. So that's a second issue. I guess I think that's it for now. There are many other barriers, but those are two significant barriers. And I guess I'll say lastly, Dr. Cooper and I have been working on a model on the Tulalip Indian Reservation whereby Tulalip tribal members who can receive health care within their own health system at the Tulalip Health Clinic, whereby we can transport them there. We can try to transport them for very low acuity illnesses or very minor things, even doctor's appointments. But we're really encountering these bureaucratic barriers to empower us to do that legally. And it's really a fundamentally simple process. And so I think this kind of a Kafkaesque thing that we're dealing with the state, we need to address that thirdly. That's it.
Hey, and Jim, I think there's two ways that we probably should look at this. One is to take part of these problems with this group to the medical program directors group, because I think those would be great advocates to help change the rules and what the education requirements are and all those things should be. And then the other avenue that we need to really take is how to really long-term fund this and, and deal with the long-term funding and have a real funding solution for this so that it can stay solvent.
All right. Dean, do you have anything you'd like to add in this?
I would just like to add that, part of the mobile integrated healthcare, and, I acknowledge the fact that if we prevent people from being transported, that can affect, negatively on our GEMT money. But there's also a lot of areas where we can prevent 911 calls that almost never result in transport. My agency has a lot of calls for people who are constantly falling, and generally they're not hurt, but they can't get themselves back into their chair. They can't get themselves back on the toilet or off the toilet. And by involving the primary care physicians in these patients and getting other social services and stuff to help these people, we're preventing those time-consuming 911 calls, which is good, And so we're developing ways to get primary care physicians involved and stuff like that.
Great, thank you. David Hanson.
Good morning. Again, David Hanson, Snohomish County Fire District 7 Community Resource Medic. I've been in this position for about 8 months. It's a very interesting position. What I mean by that is, establishing goals, in a sense, for the program itself. When I was first introduced into it, it was like, hey, kind of catch these high utilizer calls, right? And then what's that trip? So is it 3 calls in 3 months? What are the parameters here? But I'm finding often it's not necessarily those patients. Sure, we can catch those, but what about the first one that people come into the homes and they realize, oh wow, this person really needs some assistance here. It's to prevent those extra calls. I guess if you're trying to establish reimbursement, what is measurable results to get reimbursed, right? I mean, if I help somebody out their first time, whether I help them with caretaking needs, or if I help them out with, whatever services that will help them prevent 911 calls, how do you measure that, I guess, in a sense? I can see that being a challenge. So I look at this program, with the department I work for, as really a benefit, just as a service. A service just to say, hey, look, thank you for supporting us. This is me personally, my opinion about it. But hey, this is a service. I want to be able to help you out. I mean, I've been a counselor. I've been somebody to, basically to get, taken to their primary care physician. At that moment, I've even been a form where I get families to get together, talk about the challenges, to find out that some, I know Medicaid versus Medicare, understanding that and the reimbursement process of that. Most of my patients are Medicare, and most of my patients are elderly, and there's not a whole lot of caretaking needs. There's going to be a sacrifice on the behalf of the family member, what they got to do, and explaining that, and are they willing to give up for that so they don't call 911 or have the frequent falls or get the caretaking that they need. So it's a very interesting dynamic in a sense, and obviously establishing demographics and social economical dispositions, I guess, or populace play into that. So yeah, I mean, there's as I talk to other community resource medic around, they deal with more homelessness or addictions or mental health, or nearly 20% of our falls calls. So I think it really is an interesting question to kind of ask, hey, what does it mean to you, in a sense? But lots to unpack, lots to talk about, hard to do in one breath here. So thank you.
Great. Thanks, David. Jeremy?
Well, my perspective is very limited in that I'm an analyst by trade, and so I don't provide direct care to patients. I can only speak to the technical challenges around. Well, I'm also a registered health information administrator, and so when you come from hospital land, reimbursement is not really up in the air. It's a very, very straightforward process. And so my primary function is basically to facilitate. And so one of the advantages that hospitals and established clinic systems have is that they have robust information gathering and reporting systems. And I can speak for Whatcom County that has been a major part of our initiatives to make sure that we have the information infrastructure so that when policy does come down range, we can say, well, this is how many people we treated, this is how many people we were able to reduce their utilization, but we still experience the exact same problem everyone else is having, which is how do you get reimbursed, or how do you establish on the information side of things, how do I establish a value for something that didn't technically happen? Just it's a very ethereal kind of thing to try and sort out, but the impact is undeniable. Well, our program's been running, started in 2015, and we keep adding staff, and one of the encouraging things is that no matter how many people we bring on to do interventions for patients that are more focused on law enforcement side of things versus the EMS side of things, is that our community has a tremendous need for these kinds of services. Our next challenge is to figure out how to convince the government to reimburse us for them.
Great. Thanks, Jeremy. Appreciate that. Ken.
Hi, I'm Ken Dubuque. I'm the chief in Port Angeles. We have a very successful program. It's working very well. I can talk to a couple of things that have been brought up already. So when it comes to funding, GEMT clearly is a big deal. GEMT is a huge part of it, but I don't think there's an actual loss if a community paramedic treats someone who doesn't need to get transported. The only loss occurs if indeed you were going to transport anyway. And in our case, most of those community paramedic interactions would not have resulted in a transport. So we don't consider that to be a loss to GEMT because they wouldn't be transported anyway. The GEMT does factor into the funding, obviously. I think what everyone needs to understand, I'm not sure that everyone is aware of the healthcare authorities treat and refer reimbursement program. Right now, there are only 6 fire departments in the state that are participating. the Healthcare Authority in July rolled out a program for treat and refer specifically for fire departments that have a community paramedic program so that they can charge when a community paramedic responds or when the 911 crews respond, and then treat and refer a patient but don't transport. The problem with that is that JLARC, the Joint Legislative Audit Review Committee, is looking at that program and saying they don't think it makes sense and they want to get rid of it. So we have been working with JLARC. I've been working with the Washington State Chiefs Association to try to come up with a way that we can convince JLARC and the legislature that this program will work. HCA simply needs to expand it. They need to promote it better so that more fire departments understand it and more fire departments participate in it. I would suggest that if there's anyone out there in a fire department that has a community paramedic or what they call a CARES program, and you're not aware of this, you really need to become aware of it and do the research. Look at the RCW that covers it. If you have any questions, you're absolutely more than welcome to contact me. But the Chiefs Association is going to be working to put together some proposals for changes in the legislation to try to make the HCA program more accessible and have a better return. So if you're not aware of it, I would really recommend that you do some research into it. The other thing is, I know that there were people talking about, I'm not a medic, just right off the top, but people were talking about what medics can and cannot do. We have expanded the scope of our community paramedic simply by working through the medical program director. And so our community paramedic is providing field injections of antipsychotics. They're doing all kinds of COVID testing. So we're able to expand the reach through the medical program director, and what she buys off on, we're just moving forward on and doing. So that was just the other thing. And then the last thing, we're talking about metrics and how do you count something that didn't happen. For us, what we've been doing is we've been doing kind of like trace checking, basically. So when we deal with a patient, the first time we deal with a patient, we then go back and look at the number of times that patient either dialed 911 or accessed the emergency department for the previous 6 months to 12 months. And then what we look at then is how many times they either access the emergency department or dial 911 after that initial contact with the community paramedic. We have found minimum of 65% reductions across the board after that initial contact. It takes a little bit of work, but the hospitals definitely keep track of those patients, and the dispatch centers keep track of the calls as well. So it's not terribly difficult to go back and find 6 to 12 month histories on patients prior to that initial contact, and then to track them afterwards. So that's how we control our metrics, and it really works really well. And again, if anybody has any questions about how we're doing it, you're absolutely free to contact me in Port Angeles. I'd be happy to help.
I'd actually like to have a discussion with everyone about that treat and refer, because it was brought to us, but my chiefs, and I wonder if Jim or Darren can speak into this. They are really telling me that they don't even want to touch that because they're worried about it affecting the GEMT. And I've approached them 3 times and I can't get a specific answer. And it makes sense. Like you said, many of these clients, we weren't going to transport anyway. It was a mental health or referred them. So it's just man hours that we're spending there. And so I don't know how that works, but I've asked. And I know that my chief is well aware of it, but I can't cross that boundary. So Jim or Darren, or the experience of what kind of, I would be interested in how much revenue you're getting from that and how you were able to make sure it doesn't affect your GEMT.
Can I make a suggestion before you try and answer that question? Because I think we're going to try to keep track of like what's the next step. I think that we need to have a conversation about that. It sounds like we could do an entire hour just about that. So Mike, if you wouldn't mind us just capturing that as like, let's do that next and make sure that we get some folks on, and Ken, just thank you for offering to kind of help do a deep dive on that. So there's a couple of folks, that I haven't gotten to. So I wanted to just do like Ron Rasmussen, and then I may ask Lindsay. There's a couple of folks who've sent some messages through the chat box. But Ron, is there anything just about this whole, are we talking about the same thing when we talk about mobile integrated health? Anything you want to add to that question?
No, I'm kind of like Rich. I'm kind of sitting in the back. I have been in my position for like 6 months, so I'm trying to learn as much as I can about it to be able to support Dave. I want to thank Nicole in South County for actually kind of helping him along, because it's outside of my bandwidth right now, so or my expertise. So thank you for that. But no, I'm just trying to learn as much as I can.
All right, great. Is there anybody else? So I went through the folks that I could actually see. Anybody else who wants to jump in just on that first question before I ask Lindsay to kind of share a couple of things that have come up in the chat? All right, Lindsay, would you mind? I know that if you could just summarize some of the comments that have come through in the chat box.
Yeah, so we have Heather Vogel who chatted in that there's a lot of people who fall through the cracks because they don't qualify for typical home health care, but still have needs that can be met by a healthcare provider, meeting them in their own personal space. Heather said that mobile integrated health means that it could be a good stopgap to meet those needs of the community that aren't being met otherwise. And then we had Melora Christensen respond to that and just saying that Melora agrees with Heather and that MIH is meeting the individual's needs that aren't able or willing to access existing services, existing client-centered services that are necessary. And then also that client-centered services are not tied to an office or a desk, that they're in a community and flexible and skilled enough to treat the whole person, and that this requires a scope of practice that looks a lot like case management or social work, but the key piece being that meeting people in the community or street medicine, transporting clients, flexible spending dollars for purchasing items for clients, and prioritization of housing and other essential services. And it looks like we have a couple more chats coming in. So it looks like Jeremy shared the WAC related to treat and refer services. The link is in the chat box. And then I see that Laura and Nicole are talking more about the reimbursement of the codes related to this. And so I think just mirroring what Liz said, definitely looks like there's some next step items here that we could have more discussion on. So I appreciate everyone sharing. Thank you.
Thanks, Lindsay. Appreciate that. So Mike, you had like 2 follow-up questions. One was like how this group feels like you can get to some consensus around MIH globally and for the state, and then thinking about how you build a group of stakeholders to create kind of that future agenda. So, you know, the notion of who should be at the table, we kind of know who's on this call, but if there's anybody missing who might be helpful to reach out to. So Lindsay, I don't know if you could put those questions in the chat just so that folks have got that there. And Mike, I don't know if there's anything else you might want to add around kind of those specific questions, what you were after.
Yeah, no, thanks, Liz. I think that's exactly what I was hoping to do is, you know, sort of get a coalition to put this all together. I don't know if that might be in the form of, so, say, a position statement or a position document that we sort of all agree to and kind of line that out. Actually really helpful to see a couple of the fire chiefs on here, especially the ones that belong to the State Fire Chiefs Association, because there are other groups out there that would probably have to help us propel this. I wasn't involved in the CARES legislation, but I do know this conversation came up several years ago. And at that time, the fire chiefs had a little bit different of a position on all of this when I think we're supporting the CARES legislation in particular. So, you know, we need to get that group vested. And I'm not really close to, for example, the nursing unions or the home health care unions. I have heard comments in the past that there was resistance against those groups. And so I think we need a lot of education work just to anticipate if there was a conflict, for lack of a better word, with, you know, pushing us through for change. People ask me, well, you know, you're doing nursing work, but what about the home health care agencies? And I'm like, you know, if you want to put a pager on at night and you want to go on that 2 o'clock code, go on it. But we're doing it now and nobody else is. So this is our response to that. So yeah, with our local group trying to put something like this together, we would definitely need to get support of these other professional communities to go down the road. And just for the group's knowledge, I'm on the state EMS steering committee representing the Washington Association of Counties. And I'm also the chair of the injury prevention committee for that group down there. And so to progress that through that group, obviously Dr. Cooper's on the line. Dr. Wayne up here in Whatcom County greatly supports these initiatives, and we probably need to engage a few of the other county MPDs on this as well as we get moving. But for starting, I would seem that maybe we put together some type of position statement or general global sort of idea of what we want to do, and then start building it out from there.
And Carl, I didn't mean to skip you and the two folks you've got sitting with you as I was going around my little picture journey. So if you guys might want to start in this kind of second question of like how you think you can actually get to consensus, and maybe it's a position paper. Who else should be at the table?
Yeah, I just added that Dr.
Okay.
Corsa, who's our MPD here in San Juan County, is a big, strong proponent of mobile integrated health as well. You know, I think it's great that we obviously need some representation from the program coordinators, the people who are, you know, actually kind of running the systems. And if we can get support from the chiefs as well, whether that's, you know, either at the top level or an assistant chief level kind of thing. Because obviously a lot of the questions that, you know, like Nicole is coming up with, and where there's some pushback in terms of looking at the large picture parts of that, I think all those pieces would be, you know, helpful to get those people in the room at the same and look at those different components of it. I mean, we're very fortunate in San Juan County that we've got a small number. I mean, we're the most populous island, and we're dealing with 1,500 calls. So, you know, a year, and then you guys are seeing that, you know, a day or, you know, in a week. So we've had some of those things that help. And I know Lainey Volk, who's our boots on the ground, spent some time in Oregon, and hospitals were a part of the reimbursement. Peace Health specifically was part of that program, and realizing that they were actually saving money by partnering with community paramedicine, mobile integrated health, to keep people from those reoccurring visits where they get penalized. Exploring that possibility, I think, is something that we can do as well. So that's kind of what I have. I'll turn it over to Lynn. Do you have anything else to add? She's here in the room with me as well.
I think you covered that pretty well. We're fortunate that we don't have the competitive issues that those other home health agencies have, because they had that in Oregon as well. So generally only one agency ever dealt with anybody. And here we all work together.
Yeah, so yeah, and that's part of the strength that we have too. We can get our Family Resource Center, our county health department, our senior services kinds of folks in this room at the same time. It's pretty easy for us to facilitate that. So that helps a whole bunch, and would love to be able to kind of help contribute that and find out the ways that we're communicating to help bring that forward to some of you guys that are dealing with more dispersed and bigger call volumes. So I'll sign off and let the next person go down.
So can I maybe ask like what might seem like a rhetorical, redundant question, knowing that you all devoted time to this call? Is there anybody who disagrees that you should come up with some kind of consensus or position paper or something? Like you're on this call because you really think we're going down the wrong direction? Because I mean, I think that would be helpful for Mike to know as well. If there's like disagreement that you should try and be coming to consensus. I'm going to take silence as, oh, go ahead, Nicole.
Liz, I was going to say, I really would be interested. To me, it feels like fire departments are really in support of CRP, but there seems to be something out there. And again, I'm rather new, but there's something about the chiefs in this, again, where the financing comes in, that there's some, it's kind of out there. I don't know who it is, but there is some chiefs or somebody that does think this will take revenue away. And so we've kind of touched on that. And I'm curious where that is in the state or who that is. Because of course everyone here is like, no, this is what we need. But there's something out there still that, I've kind of heard it. Oh, you know, chiefs aren't quite in agreement with the CRP stuff, but yet we are. So I'm curious if there's I'm curious if some of our EMS chiefs or people that deal with our billing or our EMS, if there is some thought out there that it will decrease our EMS calls, which could decrease our funding, which could decrease our staffing. I'm just wondering if that thought is still out there. Because Melissa Haney, coming from the South, has presented to some chiefs and they don't bite at this. And I'm curious why.
I agree with Nicole on the fact that we need to have a diverse membership into this consortium committee, or whatever the case may be. And simple things like I'm sure, Carl, we're one of the 6 agencies licensed to alternative transports, to alternative destinations. And that's not going to help Carl's area at all much whatsoever, because he doesn't have a local clinic that he can just transport to in lieu of the hospital. But for us in Camino Island, it's rather important. Before COVID kicked into play, we could keep our GEMT money and transport to local clinics. And we had made arrangements, which 911 transporting to clinics was never something in the past that was even remotely considered. And now they are willing to take 911 drop-in patients with 10 minutes notice, which keeps our units available, keeps the hospitals from being less inundated. Things like that are different. What South County needs as far as a CRP program and what Everett would need for one are all definitely different for each area. So keeping the community diverse and then understanding that everybody has different needs and even their own clientele in their local area has different needs as well. And we all have to adjust together, but yet slightly different.
If I can talk to Nicole's question for a second, I believe there's a lack of understanding of the GMT program, and including from some chiefs who participate in the program with an awareness of how it works, and that decreasing calls isn't necessarily, or decreasing transports isn't necessarily going to decrease the amount of money that comes in. However, I think it is viewed by some chiefs as this magical pot of money that appears, and they don't want to do anything that's gonna mess with it. So I think part of this discussion concerns more education on the GMT program, where the money comes from and how it comes in, because it is just this strange check that appears every so often with some regularity, and it's so big that people don't want to mess with it.
Yeah, and I think, you know, to Ken's earlier offer to do kind of a deeper dive into that and the treat and refer, you know, one of the things that you all might think about, and so for my team on the phone, they're going, God, what is Liz going to offer? You know, I think that, Mike, you should know that you could ask us to try and put a summary together about treat and refer and GEMT. Like, there are things that we might be able to do that you all don't necessarily feel like you've got, you know, 4 spare hours to write up a summary that you can then distribute out. You know, I think our team can help with some of that kind of summarizing and distribution kind of piece. But the reason why I asked the question, you know, because here I am, I'm one of 9. And the number of times that the Healthcare Authority asks a question like, where are the ACHs on something? And I have to go, wow, you know, the folks in Wenatchee and Yakima are in a really different place than where we are and where Seattle is. That doing a position paper where you assume everybody's in agreement is one approach. But part of the exploration is like, who has concerns? Who do you want to make sure that you're actually getting some information that's going to help them as they're thinking through this? And, you know, so that's, you all know where some of those kind of spaces are better than I and my team know where some of those things are. So that was really why I was asking.
You know, Liz, you bring up a very good point, and actually position paper is probably maybe the wrong terminology. Maybe it looks more something like, hey, we have this issue. These are all the challenges we have with this from all the various views, because, you know, Darren makes a good point that we all do this a little bit differently. I fund community paramedics totally differently, and it's not really related to transport fees, for instance. And so we're not really reducing call volume in our program. And to be honest with you, I used to pitch that, you know, hey, this community paramedic program is going to reduce call volume by X%. And it didn't really reduce call volume for us. What it did is reduce call volume on those highest utilizers that we had in the system, and we could monitor that. But our call volume is going up anywhere from 3 to 6% every year those are the normal patients that we're getting, and there's a lot of factors in that. So I think that might be a better idea, is to collect these challenges, if you will, from these, and then try to figure out what is a flexible sort of document that encapsulates that out to, you know, have an end result of some change for us.
Yeah, and it could be that some of you on the call might be the liaison or linkage, for example, to the EMS chiefs. You know, if there are those other tables where some of these concerns are coming up, you know, how do we build some bridges to those other tables so that we can know what the potential concerns are, and who knows, they could be coming up with solutions that you all might not agree with either. That certainly happens to us with the healthcare authority, just full disclosure. Sorry, Jesse. And so, you know, we're trying to figure out, like, how do we be equally informing from both directions, so that we don't come up with a solution that doesn't fit on the ground. And you know, so there's just some pieces of this. So, you know, I have like 2 additional questions, if it's okay, Mike, that I want to just toss in the mix. Because I think you've sent like an email to us about some of this pressure, and it is how you all are navigating increased need with requests that I'm sure, if they're not on your desk, they're coming soon, to decrease your budgets. And, you know, that just this notion of those 2 pressures kind of coming at each other, both for COVID, for the issues around race, social justice, you know, unrest, things that are going on, like what that means for you as you think about, you know, this model looking forward. Because I can only imagine that you're just getting called on more because people are not necessarily using their traditional outlets to the healthcare system. And just like, I would just love to get at least a glimpse of what are you being asked right now, budget-wise?
Well, I can tell you in Whatcom County, you know, a large part of what funds public safety is through the sales tax and, of course, property taxes. Sales tax for us right now are down about 20%. And so we're having to make cutbacks. I know for city of Bellingham in particular, the fire department was asked to reduce budget significantly. And actually for us, that included the loss of the paramedic position that would be funded by them. I was able to dig some money up out of our county levy to shift and cover that position for a couple of years. But that was the first thing that gets asked, right? So priorities are service or 911 calls. And so the first thing that goes are those side programs. And that's why it's so important to figure out how to fund those sort of separately, in my view, from the response, you know, type of reimbursement. Luckily for us, though, in the levy up here, a little bit of a protected budget because it can only be used and spent on EMS. And so those funds are directly in there. And that was the reason we were able to support the community medic. But that's not true, I don't think, in many of the counties out there. And I can imagine everybody else is going to start taking cuts as well. I don't know if it's a positive thing. I do know that with the rhetoric about the defunding police, there has been a lot of conversation with our county council up here in diverting funds for more social programs or social services outreach type programs. those are initial conversations. Still big picture of loss of revenue, but there is a possibility we may see a shift in how some of these things are funded out of law enforcement.
So would you all mind just like, and if it, whether it's in the chat or you say it out loud, if any of the rest of you that have started a community paramedicine program are facing a cut because of budget requests right now?
So Liz, I'll talk. Yeah, this is my main concern for discussing like these treat and refer options, because we are, our commissioners are committed to CRP that at this point. But if next year when we see, because we're a little bit delayed, and when we see a big gap, they've already asked to start taking cuts. And so right now my chief's like, well, we'll just take a little bit from CRP because we don't use a lot, but we also are very much grant funded. So if my grants run out and we start taking over those grants, if I can't sustain this program and there's cuts in other areas from our police that could affect my operations, I'm super afraid that would they take us and put us back on the line and not provide this program? So I do go, look, Medicare, Medicaid, all of our funding sources, if we want to put it into community services, police and fire's community social systems is where we should do it. But I also got to get the chiefs on board that we get to sustain this program. And how can we somehow bill for it to keep it alive without grants? That's a big concern. I'm complete.
Anybody else? Darren?
I agree, Nicole. And efficiencies of service for us to survive may be an answer as well. We're having a little bit of that discussion on the chat line. I know in North Tucson, when I was BC down there, we had a similar program. And after 5 years, the program lost funding. We weren't able to run with it. And we were beating our heads against the wall. And once we advised the hospitals, because we had a very good system set up to where we would do follow-ups post 30 days of their patients and help them from being readmitted. Once the hospitals realized we were no longer running with the program, they then decided to fund it. And I mean, that was a chance. That was just blind luck that we were able to push them into that. Why pay for something if you're getting it for free? So there are abilities out there. There are options. Unfortunately, COVID's kind of given us a little bit of a hiccup as far as what we should be doing. And even our departments have decided to completely adjust the CRP program for the interim and try to address the COVID idea with our CRP program as opposed to anything else. So we don't want to transport to local clinics, which is what we wanted to do. We have a lot of good ideas here for, getting the state, understanding what CARES is, understanding what our reimbursements are through GEMT or transports or non-transports, and we're all doing the same work. It would be nice if we had a more functional head or one or two people would be assigned the tasks come forward. Maybe it's ACH that we could have a bullet list and expectations, objectives of what we're looking for and find resolutes, because one fire chief will say one thing and another. And that is a problem. We're not doing the wrong thing. We're just doing what we're used to. And I think maybe CRP MIH is where we start changing and adjusting how we operate.
Jim? Reinhardt, anything from?
Yeah, well, I guess to follow up on what Darren said, who I think, Darren, you're down in Arizona by the cactus behind you, right? Yeah, I think that he really brought up a key point in that we have got to come up with a unified message, not just with each other, but I think we have got to move forward with a unified message to the legislature. Everybody in this room, I suspect, are real aggressive advocates for MIH, otherwise you wouldn't be here. But sometimes we're our worst enemy, because I think that the individual MIH programs that we all have, like I work on an Indian reservation. This is much different than where Nicole's working down around Mariner High School. We have these different programs, but in the end, we know that this does work. It does help save healthcare dollars, and operationally, it positively affects our agencies. We have got to, however, go to the state with a unified message to say, this is the direction that we want to go. And for my very, very small, humble part, I'm happy to work with anybody else. Mike Hilly and I, we've worked for many decades together. I'd be happy to move forward with him to bring this unified message down there to Olympia. But we also have to kind of get on the same page and what are we trying to accomplish? And that I think that I know it changes from district to district, from agency to agency, but fundamentally we're trying to kind of break down some of these healthcare silos and bring legitimacy to community paramedicine. And that's something that I think that we can accomplish for my part.
Carl?
I'm sorry, Liz, were you asking me something?
Yeah, just if you just had any other thoughts. Sorry, I just kind of keep scrolling through my.
Oh no, that's fine. In fact, you know, because I like both I have Lainey and Kyle here, and you know exactly what Jim was saying and Darren was saying. I agree completely. I think that if we can come with that message that's solid, and I guess the discussion that we were having here was why not if we take, you know, obviously Minnesota's been held up as kind of an example of a well thought out program. It's there. It's been adopted. Why not use that as the template, bring that forward and be able to come and say, well, here's this tweaked for us here in Washington. We're not reinventing the wheel. Why do we need to? And push that forward. And maybe that might help us as well as to say that here's another state that's had a robust program in place for a long while, and they've done the heavy lifting for us. We'll just follow on their coattails. Just a thought.
Yeah. So Mike, do you feel like you have the information that you need? I mean, you were kind of the impetus for pulling this call together, number one. So not putting it on your shoulders, but do you want to know what the list is that I made? Because I'm kind of like, whoa. So there's an upcoming legislative session. To be honest, like, you know better than I do if there's something in there. There's the WACs, which sounded like don't need to have legislative response, just like has those things get reviewed. There's reaching out to HCA for whatever the range of issues are. This JLARC was really kind of a fascinating piece, which I hadn't heard of before. There's how this connects with like the steering committee that you're on, the various other associations that are going on. And then, you know, just like some possible next steps is, you know, actually just having a very specific call to learn more about the treat and refer and the GMT. Yeah, I'm sure there's more because we're.
No, I'd love to collate all that together. And I think generally the group is, has from what I'm feeling anyway, sort of a general idea that, you know, NIH is a cool thing, and, you know, creating that big flexible box that we can build this in. And actually, Dr. Cooper did remind me that, yeah, the rulemaking process is through the state EMS Steering and Trauma Committee. In fact, it's a subcommittee off of that group. I've never navigated that process before. However, I know they just got out of some rulemaking changes for some other areas of the RCW. So, you know, as we move this along, this has to be presented through Katie Holstein's office, and actually her boss, Dolly Fernandez, really holds that key to moving that to the next level. I do hope that we sort of put some oil in the squeaky wheel. We did have the governor come up and one of their legislative assistants here last fall, and actually Captain Joe Frank of Bellingham Fire Department spoke very eloquently with that group about what we wanted to do up here. So they've heard it from their end, and they saw a little bit of success for the program. And so as a group, as we move this, I think it would be developing all those things that we talked about. We can make that list. I can help put a paper together that expresses that. Maybe move that back out to the group for a look, for editing and just some input. And probably not a position paper is probably not the best word. Maybe it's a concept paper or a proof of concept paper that we want to move through to get this idea going. And then generate, you know, support through our medical program directors. And we'll have to work the fire chiefs on this a bit too, because the fire chiefs are represented in that EMS Steering and Trauma Committee as well. And at some point, probably the international IFF. I know that they have a small section devoted to community paramedicine out there, and they would probably help push agreeable legislation or rulemaking through the RCW process as well.
So you feel like you got what you were after?
I think
Hopefully,
so.
I want you to hang up feeling like you got what you were looking for.
Yeah, no, I did. Thank you very much. It's just getting us all together and forming a group. And I'm sure Lindsay has a collection of all the email addresses, and we can start some communications back through those methods too.
Yeah, and actually, I actually have a note to myself. If you all wouldn't mind, please chatting your email addresses into the chat box, because there are a couple of folks on that I'm not sure are on the Zoom invite, and I just want to make sure that we've actually got the best way to keep this group connected. So that would be awesome.
Yeah.
And, you know,
sorry, I was just going to jump in really fast. We did do registration for this meeting, but I noticed that there are some folks who are logged in under somebody else's name.
Right.
Those, if you could just get your email in the chat box.
Yeah, that's kind of why I was asking that. You know, and I think one of the asks that I would have of you all, you know, I know that you know that we've got like a team at North Sound ACH address. You've got the project managers. If there are some things that are specific to like a funding crisis moment that you're facing, I would really appreciate if you would include me in those emails, because, you know, the ACH, for better or worse right now, has flexibility in how we use our funds that we may not have a year from now or 2 years from now. And so, you know, we've been really trying to pay close attention to where there are some cracks in capacity. And so we have partners, including many of you, that we're paying because you're doing a project. We have some ability to support, like, not losing capacity across the region. So, you know, if you would just please include me, as you've got, you know, county commissioners, county council, or anybody that's going, hey, you need to cut this position. Please include me in the loop on that. And we just will see if there's some way that we can step in and help with that in this interim period. And we've been doing that for a number of partners who are not our implementation partners, but just like really critical services around.
And Liz, just to clarify on that, is that offer only for folks who are in the North Sound region?
Wow, what a great question.
I know we have some folks on the call that aren't in those 5 counties.
I would say that the dollars we have are for the North Sound region, but if you're outside the North Sound region, you know, I just know that all of the ACHs are doing the same thing. So happy to make that connection if you're outside of the region. And I guess, you know, on this HCA piece, since I feel like I talk to folks at the Healthcare Authority 3 times a week, I'm on a Zoom call with them of some sort. If there's a way that we can be a leverage point around what you all need from the Healthcare Authority in terms of rules, funding, reimbursement, I also would ask that you all just like put some pressure on us to help leverage some of those conversations. You know, we've been just entered into some conversations about how the federal CARES money coming into the state, how it's being used and deployed. Some of it is earmarked, some of it not. And, you know, really this conversation has been incredibly enlightening for me because, you know, we are one of the ACHs that committed to implementing the community paramedicine program, but I'm not sure that we have shared kind of the depth of information that you all have shared today across the state and back with the Healthcare Authority. And, you know, we could definitely be a better ally if we had some of this summarized the way that, Mike, you've been describing. So you all should be expecting us to carry some of the water on this as well.
Thanks so much, Liz. Appreciate all that work. Absolutely.
Okay. Does anybody have anything that they'd want to say before we close up? We were scheduled to close at 12:30, right?
Yeah. Looking good, Jim Reinhardt. Like that haircut.
Liz, can I ask one more question off the topic, kind of?
Absolutely.
Okay, so just thinking CRP consolidation, is everyone utilizing Gelada as their reporting?
We are
I,
soon.
okay.
We will be implementing here in another couple of 3 weeks. We had a hold up because of COVID and other things, but we love it. In fact, we put it in service down in Rebin when I was working down there, and I think I saw Liz Downs on the call. It's a great program. We're really loving it.
We're on Gelada, but frankly, we've kind of shied away from it because we found that it does not dovetail or integrate very well with the Tulalip health system. And so for referrals, patient care management and tracking, it doesn't do well with our Native American clientele.
Yeah, Nicole, we're using Gelada as well, and kind of paid for the bridge between ESO, which is our normal EHR reporting, and Gelada, and have got at least those two are talking to each other, and we're liking the Gelada program.
Cole, we looked at it, but we decided against it. We're going probably on the road of something called Unitas, just so you know.
Mm-hmm. So we
Tacoma
could,
Fire,
oh, sorry.
Tacoma Fire, we're using Image Trend for both EMS and our community cares program side.
Yeah, and so if you all are interested, we, you know, and I'm saying we very generously, Lindsay can help try and find a time for that next conversation about the treat and refer and the GMT. You know, we might want to schedule a time to talk about Gelada and kind of how North Sound is thinking about, because we also have, you know, another platform for a care coordination hub, and just how we're talking about the interconnectivity and the bridging of some of those things. And I think, you know, really, Jim, to your comment, you know, we've been looking at a couple of integration tools that would help bridge some of those things that aren't connected now. And, you know, that just feels like a real missing piece. So we could do a follow-up call around that as well.
That, Liz, that would be great, because I think, again, as we do integration, finding systems that help us coordinate our care, and there's a lot of different options, and I was curious what's working for people, what's not. So I'd like that discussion too. Thanks.
All right. Well, I'm going to close us up. Many thanks to Mike and Lindsay and Amanda and Vanessa for pulling this together. I feel like all I've really done is make their lives a little bit chaotic in the last couple of days and trying to pull it together. But they did a lot of work in pulling this off. And, you know, just number one, just thank you all for the work that you do on your day-to-day basis, but finding the time to get on this call, really lots of gratitude for that. And hoping we can help you do what you're doing more and better. So thank you.